Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attends every 6 months and they suffer from otitis externa in their left ear. And you may have noticed that the entrance of the ear canal is very red, inflamed, it's quite narrow, which makes this procedure quite difficult. And what this patient has in their ears, it's not earwax, it's just dead skin, dead keratin. Some patients with otitis externa, because of the inflammation, they have a high turnover of dead skin. And the skin, if you've been watching my channel, you would know that the skin in our ear canal, as it dies and sheds, it should naturally migrate out of the ear in a conveyor belt motion. So the ear expels itself of any old and dead skin. But in this particular case, this patient has such a high turnover of dead skin because of their otitis externa. And because of the inflammation at the entrance of their ear, they get an accumulation of this dead skin. And so this is not keratosis obtrans yet, but anyone who is new to the channel is not aware of what keratosis obtrans is, and I refer to the YouTube channel, please visit and you can look at the playlist, and I've got a whole playlist dedicated to keratosis obtrans. But basically keratosis obtrans it's an accumulation of dead skin cells which then engulfs the inside of the ear canal, and it grows and it can start remodeling and widening the ear canal itself. So patients with keratosis obtrans, the number one hallmark symptom is pain. Now, this patient wasn't experiencing pain, so automatically we can say it's not keratosis obtrans, but they were experiencing itchiness. You can imagine having this dry skin in your ear. It's almost like shards of glass, some of it is, and the exterior surface is like sandpaper. So as I was removing it, the patient could feel it. This gives you a great perspective of how inflamed the patient's ear canal entrance was. Initially, I was going to use the Waxscope. So the Waxscope comes with a specular, which is traditionally earwax removal in the UK when you perform microsuction or manual removal like we are here. An endoscope still isn't the most popular method or the widespread method. A lot of people use it, but there is a high skill level involved with an endoscope, and a lot of people are already so used to using a speculum, a microscope and head loops. It's what they're accustomed to. So there's several reasons. So with the Waxscope, I've developed the Waxscope to make the procedure a bit more user-friendly, because as I mentioned, using an endoscope can be quite tricky. But I couldn't get the speculum in, it was so narrow, then I used a traditional speculum that we have, and the Waxscope, we've got 4 different sizes, and so even the smallest one, which is smaller than anything else that is on the market, it just couldn't get it through that entrance. It was a tight squeeze. So for me, this is why an endoscope is so unique and so advantaged, because if I didn't have the endoscope, I'd really struggle removing this. I really would. So I would suspect the diameter of that narrowing of the ear canal is probably about 3 millimeters, and that's because in the ear right now is the ulnar suction probe. You can see there's hardly any space either side, and that ulnar suction probe is about 2.1 millimeters. Now I've just instilled some oil. On previous visits, I've actually had to ask the patient to assist me and pull their ear back, retract it, bring it back and up. But today I managed it without doing that. It's probably the only patient. I got one other where I either get the patient or a clinic manager to assist, because there is that narrow. But in this particular case, even pulling that ear is not going to make much difference. It was just so inflamed, it just wasn't going to stretch. So I'm using here an ear pick device. Actually, this is suction here, sorry. I'm using the fine end, but I initially used the St. Bart's ear hook, then I reverted to an ear pick, managed to just about squeeze the forceps in. And there was multiple layers of dead skin plugs here. So when you remove one and you see another, and when you've got a plug like this and you've got such a narrow ear like this, what can commonly happen is when you're trying to remove the wax, especially with manual instruments, you can inadvertently push it back deeper into the ear, which is obviously what we don't want. Now, once we get through this narrowing, the ear canal balloons out. So it's a normal shaped ear canal once you're through this narrowing. So this plug of dead skin has accumulated in the wider part of the ear canal, so it's significantly larger than this narrowing, and so we're trying to bring it through. This ear pick's really, really useful. It allows them to go over and in. You've got to be careful though, because the tip of the ear pick is quite sharp. And in fact, I'm developing my own range, and we've got an ear pick slightly different in concept to this, but probably a bit more user-friendly as well. So hopefully in the next couple of months we're going to launch that. So that's the major plug of dead skin. You can see once we're through this now, and the ear canal does widen, so it's quite decent size. The ear canal is also quite inclined. All of our adult ears anyway, they do tilt upwards. I think the average is about 32 degrees. But I would say, based on that average, this patient's probably about 40 to 45, so it's significantly more inclined, which is useful to know, because when I'm digging in these instruments, I don't want to penetrate too deep, because I've got to factor in that this patient, although we can't see it at the moment, I've got to factor in my mind that if I dig the instrument too deep in, I'm going to make contact with the floor of the ear canal. So it's useful that I've seen this patient a few times, and I've documented. So when we make our notes, I always leave little tips for myself, so things that I learned in the procedure for a particular patient, so the next time I see them, it will help. So I just thought I'll try and get the St. Bart's hook in again, and that's because that's got more of a rounded tip at the bottom. So I was just a bit worried with the ear pick as I was penetrating that I might dig into the canal. So that particular, I mean, it's still, I know it's rounded, but it's still, it would be uncomfortable, but it's less likely we're going to cause trauma, so bruising or cutting in or brazing to the ear canal. So these are just some more drier pieces, and it's literally like a shard of glass when we brought it through, and actually felt it in my fingertips, and you can feel it through the glove. It was quite sharp, so you can imagine what this has been like. It's almost like a razor blade in her this patient's ear. So I'm just trying to tease that through. So with this patient's otitis externa, and it is more lateral, it's just the outer third, it's of the cartilage portion. They've seen dermatologist, ENT, and it's just about managing it. It is a chronic condition for this patient, unfortunately. And they're doing everything right. They're not poking in the ears, they're not getting water in there. So again, this is a great perspective of how narrow this patient's ear is. So I tried to get use the forceps in that angle, but I've just rotated it the other way. And I've just about got enough grip there. Pulled it through, and I'm actually just using the tip now just to poke in and just extract it. So the forceps came good in the end. Previous to that, it wasn't really helping. In fact, it was pushing it further in. You can see that slope upwards. So the ear canal goes up, and then about 0.5 centimetre away from the eardrum, it suddenly goes down. So it's almost like a ski slope. So this patient's got quite a prominent inferior recess. Now, I just wanted to get all this out because, again, this patient, I should add to this patient has got no hearing in this ear. This is their dead ear. They have developed profound, absolutely lost all their hearing following suffering from mumps as a child. So they've got no hearing in this. We're not removing this to improve the patient's hearing, because they haven't got any hearing in this ear. It's purely because the patient can feel the irritation and itchiness in this ear. Now, this patient does sometimes suffer from earwax in their good ear, the right ear, and so with that, whenever we didn't need to remove it today, but whenever we do that ear, we avoid suction, just because we don't want to introduce any noise unnecessarily. So I just do that manually where possible. And this patient used to have their ears irrigated, the right one, but that's against the guidelines. If you've got one ear, and you shouldn't be irrigating that good ear, just because there's more increased risk of that causing trauma and damage to that ear. So the patient's fully informed now, and they avoid obviously getting water in the ear. So we're just mopping that up. Just going to re-enter. There's this probably a mild attic retraction there, but the eardrum's fully visible. And it doesn't look a lot, but in that patient's ear, because it was so narrow, it was actually quite a significant build-up. And patient was relieved to have that all removed. They feel a lot better. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.